All right, so Mr. Ioan Muntean is with us from the University of Texas, Rio Grande Valley, and his talk is going to be titled Digital Phenotyping and Precision Mental Health with AI, Unity Collapse or Pluralism in Psychiatry. So please go ahead.
Thank you. I just need to ask you if you see a slider. If you see my slide. Yes, good. All right, it's late for you guys. For me, it's super early. And I enjoyed all the talks. I was very sleepy at the first talks today because it was 2 a.m. But thank you. Thank you for inviting me as a keynote speaker. I feel very honored about this, and all the talks were super interesting. I try to take you on a little journey here. Is everything okay there? I don't hear you, but if it's okay. Okay. Is that okay? Or
just a second. It's fine. We're just working on like.
So we can see your slides on Zoom, but we're trying to make them available on the projector as well. So we're having a very small link. It's the same thing that happened to me.
Yeah. Well, again, thank you for inviting me, and we'll see how it works.
All right, so sorry, we found a a makeshift solution. So please go ahead with the talk. So we're
Okay. I mean, yes, thanks. If you see the slides, it's enough. Thank you, Elena and Sandra. Yeah. All right. So my big problem here is to integrate this talk in what I've heard from you. And there are two things that won't integrate well. And one of them is I'm not going to talk too much about LLM here, but I do talk about AI and different other models. But there is a little bit of discussion on LLM, probably connected to Sandra's talk and to talk yesterday. But so the big starting point for me is a bunch of things which I'm concerned and everybody's concerned of. And starting points with concerns are good in general, but I would say if you are familiar with this, the state of psychiatry and psychopathology at this moment is very, very interesting from a philosophical and philosophy of science point of view, from a sociological point of view, and many, many other issues are there, sociology of science, history of science. But the second kind of starting point, but a query and a big concern we have is this datafication. I know this is not common word, but people use it. Datafication towards in science and many other disciplines, but in science, social science, natural science, philosophy, humanities, everywhere. And then you have the AI drive. The AI drive meaning let's use it as a tool or anything in science, yes? Okay, the other concern starting point is the lack of trust in all these disciplines. So scientific fields, we lost trust in many sciences. You basically can read or look on different newsreels how we lose trust in science, we lose trust in institutions, we lose trust in government and so on. All right, so we have also the AI scare and the big data scare that people are still trembling and they're shivering their timbers, if you want to say. All right. So I'm taking here a good, if you want a more positive stance and say, hey, good, look at the next slide in which I say, hey, there is progress. If there is progress, and scientific progress especially, there are various ways to look at the progress. And there are interesting let's say, smoother changes, which are not revolutions. They are not reduction, annihilation, and falsification in Popper or others. These are just corrections. So corrections means, and I don't want to get into all the trouble of discussing corrections here, is that you correct and rectify something that is existing. So I'm going to look into this. In the paper that I wrote, I explain why you shouldn't expect revolutions in psychiatry based on what I'm going to say, the AI impact on it. But I'm looking into the corrective part. So corrections within the discipline made by, and I told you already, AI and datification. So yeah, some scientific disciplines can self-correct in the face of evidence. That's very corroboration story, or can falsify, of course, that's Popper, but some corrections are external. All right, so external corrections, that means the discipline stays self-sufficient and, if you want, happy with what it is, and then something from outside comes and correct it, yes? So that can be from other disciplines, from outsider, this institutional, the Canson things that I've heard discussed yesterday, can be by new methods. You bring in statistical analysis, calculus. The point is, it's not only the simple connection between evidence and theory or models that can correct some theories or some domains. It can be something external, right? It can be a social factor and so on. Now, this is the part that I'm interested in, this last bullet point. Can a new technology, can a new advancement in technology correct a scientific discipline? Can technology influence the path forward of a science? Yeah. So I would say this is the claim of this talk, and the paper has a couple of other ideas that I will put at the very end. Yes, different areas of psychiatry as we know it can be corrected in the sense of this second bullet point here by these technologies, and I had 2 or 3 in mind. We will start to focus as much as we can on AI rather than on datification. That's a kind of different topic, but these two together can do that, can correct. All right. So this is the proposed aim. I have only one, sorry, not plural. Analyze different ways in which datification plus AI can correct the path forward in psychiatry and psychopathology. And I see different positive ways to do that. When I talk about coherence and cohesiveness, that's a part of the corrective part in which you increase coherence and cohesiveness. And now that can be done by eliminating different models that are not exactly at place. They don't work as expected. And there are other ways to do this in a different, but we kind of want coherent and cohesive disciplines around us. All right. So this is a little bit further away, but I think we are going to be forced, we like it or we don't, to accept this kind of distributive epistemic virtues over different agents, epistemic agents like the therapist, the AI, pathologist, neuroscientist, data scientist, and so on. So the point will be we need to distribute these epistemic virtues over the community. And at the end, I will suggest we need to distribute even the moral virtues. Okay, this is something that I kind of think about, distributive moral virtues in this domain and many other domains in which you don't have like an expert in everything that dictates what to do, but you have these distributed virtues, epistemic and moral, over different agents. All right, so this is a blowhard aim. To distribute the epistemic network, epistemic virtue over networks of agents. And I kind of put a couple of them in the case of psychiatry. As you see, there is something like an AI agent there, and there is a data scientist. And this would be kind of the idea that hopefully I'm very interested in the feedback from you. People talk about distributive knowledge, cognition, distributive work, tasks. Problem solving is distributed. So this is kind of the story. All right. When I'm doing this in a different context, I will present it in Michigan. I will talk a little bit more about progress. Now, I don't want to impress you. I don't want to, take you too far away, but progress is very important in science and in society and political progress. And I probably saw this in different talks here, but we know that progress can have units of progress. So what is progressing? Yes, what is the engine of progress? And you have this kind of epistemic, like Bert says, it's accumulation of knowledge. You have more knowledge and you accumulate it. It's not that you add some knowledge and you delete something. No, it's simply adding. It's cumulative knowledge. Yeah. The other is cumulative of true beliefs. Yes. So that's Robobottom. And you do accumulate new beliefs which are true, and you eliminate the old beliefs which are not true. So you see, it's not the same thing. The first one is strong. The second is only about beliefs. Noetic one, Delson, he talks about, we increase our understanding. And I don't think you need to add knowledge or beliefs, but understanding is better by progressing. Then you have this, Sean is the person that I will use more. It's like functionalist. The progress happens when you solve puzzles. This is kind of like pragmatic and Deweyan. Kuhn, Loden, and Sean, you solve different problems. More problems are solved, fewer problems are occurring and emerging. So you say the number of problems, or if you enter relative density of a problem, goes down into a discipline in time. All right, and Douglas talks about this. In fact, all these epistemic virtues of theories, prediction, control, manipulation, intervention, and of course, explanation, I don't know why I didn't put it, are all of them together have to improve in time, fast, if you want to talk about progress. Okay, so I think Sean functionalist will work for me because, of course, I have to pick one of them. And I think the problem solving is part of my story here. Now, Douglas talks about interventionist progress. I will mention it at the end. In what sense you can talk about interventionist progress in, let's say, psychiatry. Okay, but the functionalist one works for me, at least, yeah, for the time being. Maybe I'm wrong, but that's the one I picked. Okay, so I'm trying to pick the one that works for me. Okay, so, all right, crisis, yeah. I don't know if it's a good idea to talk too much about this because there is so much, disengage, unearthed perspectives about psychiatry, and has a divided nature and a very unpleasant history. So the history of psychiatry, psychopathology is unpleasant in itself. And I don't want to get too much into this because we don't do history here that much, but these are some controversial parts: over-medication, wrong way of dealing with diagnostics in brain surgery, brain intervention, very, very intrusive brain interventions. Tekin has a new book. Maybe actually I have access to it, but I started to look at it. She has a couple of chapters sharing Tekin on the history of DSM, which is, it's supposed to be here. This is called Diagnostic and Statistical Manual of Mental Disorders. Probably you know it. She traces from DSM-1 to DSM-5. And okay, there are dramatic changes. Now, when I say dramatic, this is like in fact, it's a euphemism. It's not dramatic. It's extremely traumatic and not pleasant. In any case, high top, I'll talk about this. It's a concurrent model. It's competing with DSM and its hierarchical taxonomy of psychopathology. And I'll bring a couple of ideas about this. Then there has a turn in 1991, the brain circuits by Kendall. He said we bring psychopathology is the discovery of the wrong circuits in the brain. Very strong thesis. The genome turn, I think that's 2000. And that discovers different genes. And we'll talk about this in precision medicine. And after that, it came the precision turn. Now, precision turn says psychiatry has the wrong unit of analysis. Their ontology is wrong because they talk about diseases, disorders. We have to talk about patients and human individuals with a very strong fingerprint of what they are mentally, of course. All right. So, at this, you can add datification and AI in psychiatry, which happened in the last 2 decades and so. I don't want to get into this, but we have a long history of philosophers fighting and quarreling with psychiatry. Of course, Foucault, Jaspers, this is in the 20s, an excellent book. I started to look over it. But Foucault, of course, everybody knows. I know a bunch of other philosophers working on this. It's not only one. There is a philosophy of psychiatry textbook, I think, Palgrave. But in any case, philosophers did quarrel and fought the scientific status of psychiatry. Now, I want to clarify something. Psychiatry is part of medicine. Medicine has 2 major components. It's a science, it's a natural science, and it's an institution. And because it's an institution, it's much harder to catch it in a philosophical framework or a philosophical bed frame. Okay, it's not only that philosophers fight the psychiatry, but it's psychiatrists in themselves. So Rust is a new book, and Insel. It's interesting that both Insel and Rust talk about this huge gap between what we know about psychiatry and disorders and conditions and the divergence, neurodivergence, and what we can do about it. How can we intervene in it? So if you think about progress as interventionism, then Douglas will say this discipline is stalling badly because it's increasing the knowledge and understanding and does nothing. There is no cure and progress in respect of intervention. So I mentioned that. But of course, Insel and Russ said that. And there are a couple of other identity problem. I just talked about this. Is it an institution? Is it a science? Is it a practice? Or is it a tool of oppression? Well, that's, of course, Foucault, tool of oppression. Yeah. And then there is this Tekin, Freud, and Jung camp, philosophers and, of course, psychiatrists, psychoanalysis, who says, oh, you are studying the wrong thing. It's not behavior. It's not genes. It's not brain circuits. It's the self. Yeah, so that's Tekin. It is the self that you have to study in this discipline. All right, good. Then if you are interested in, how to say, philosophical inputs in psychiatry, people talk about this mind-body problem, yeah? So this is Insel saying in 7 years ago, oh, we have a brainless psychiatry, too focused on psychological, social, and behavioral evidence, and a mindless one. Okay, that's a former thing. Too much focused on neurological or genetical factors. Yeah, so that's Insel, one of these. He was the director, I don't know, NIH, Institute for Mental Health and Hygiene or something like that. Okay, and then the embarrassment of richness is what is the unit or the target of treatment? Yes, can be the gene, the brain, the mind, the social environment, the self, that's Tekin, or everything together. So what are you treating when you treat a mental disorder? Yeah. And this embarrassment of richness creates a plurality. Nice word. We like it. But creating inconsistency. Thumbs down. You don't want that. So then my question in this paper is, what do we do in respect of AI and datification when it comes to this situation? And I have a little more of, let's say, formal part in which I said there's a problem of stop the evidence. When do you stop collecting evidence? Why is this a problem? We have so many models and the plurality of models. You have a model that collects evidence and they say, don't collect evidence on that side. Yeah, if I'm going on brain circuits like Kendall, say, stop collecting data from genetics. If you work in cognitive-based behavior and you say, stop talking about genes, stop talking about biomarkers, just let me deal with the social environment in which this patient lives. This forced stop the evidence to the other models is deteriorating the trust in this discipline. Yeah, I don't know if it's clear here. It's a stop problem that people talk about. it's generally in science. So when do you stop collecting evidence? Why collecting evidence is not good? Because it's expensive, take time. When, let's say, my car stopped working and start to collect evidence, and I see I don't have a battery, somebody stole it from my car, I don't need to collect more evidence. That is the evidence that my car has a problem with the battery, and I stop collecting it. And if you compare other parts of medicine, cardiology, cardiology is not like psychiatry. It doesn't have the same problems because the heart and the blood system and everything that connects to the blood, it's measurable and operational, and you don't have this kind of conflicting models. Okay. I am interested in this. Which of these technologies will change radically the situation in, not radically, but correctively, in the sense of correction and rectification. That's the word. Okay, so rectification of the landscape of psychiatry now. I say AI identification is what I look at. There is this new method. I don't want to talk too much about this, optogenetics, and then there is the brain dynamics, new methods of collecting data. Okay. Okay, so I would say here, let's move into the nice part of it. The nice part of AI in psychiatry, as far as I understand, is the predictive value, that it can predict treatment and diseases, or in this case, action, the suicide, better than human therapist, yes, or human psychopathologist. And there is an explanation for this, and they do it better than humans. Franklin talks about this. There are some graphs. I don't want to project graphs too much, but there is a better, the AI systems are doing better than humans. All right, so that's the good news, yeah? You can explain this by saying the theory doesn't exist yet. We don't have a theory of psychiatry, psychopathology. Therefore, throwing these models on the data and try to predict from them without going through the loop of a theory works. Okay, so that's one thing that is good news. Yeah, so AI predicts this rate of suicide, giving different patients better than humans. Okay, now let's move to chatbots, because LLM is the topic of the workshop, the conference. I want to warn you that chatbots you'd see here, and I put a bunch of them here, WeBotB and MyCompass, are not actually LLMs. They are commercial chatbots, which are trained on a specific mental data sets, and they are covered by FERPA regulation, and they save your privacy. All right, so this is the good news. I know that Terik talks about MyCompass, and she doesn't like it. But these are chatbots which are kind of professional chatbots, right, for treatment. The problem is then there is ChatGPT, and it is used as emotional support by millions of people. I have some data here. Those who use Claude, 0.34%, under 1%, 1/3%, use that Claude as a mental support, yes, emotional support. In ChatGPT has 5.3 billion hits monthly. Even that percentage is getting into the 20 million, yes, more. Something, 18 million sessions of using ChatGPT as an emotional support, okay? And what is this used for? Here are some percentages. Ruth Marier, this is the data, says that this is used this way, right? So when you feel lonely, 35%, 73 anxiety, 63 personal advice. I have a lot of like prompts, examples, and it's used, yeah. We use ChatGPT to cheat on our classes, to do research, and people use it for anxiety problem, advice, depression, being lonely. So Rosemary and Vash says, AI is probably now the world's largest mental health provider. Scary, not good. Because there is a scarcity of mental health professionals everywhere in the world. There's no country in which you can match the number of people who need this service with the service providers. So then everybody goes to ChatGPT. People talk about this, and there is Rosemary and the others from this Salito Institute, they did a couple of surveys. And here is what they say. 1/3 of the respondents says, ChatGPT is worse than the human therapist. 1/3 says it's kind of the same. 1/3 says it's better. So I don't know how serious this is. It's serious in respect of replacing human therapists with chatbots, with the version which is ChatGPT. I'm not talking about the three other commercial ones, because those are expensive and they are not free. But everybody jumps on the free lunch, yeah, and then they get to ChatGPT, yes. A couple of papers here that are just published saying that mental health stigma is perpetuated by an LLC. So I give you an example here. This is a stimulus. I lost my job. What is the bridge is taller than 25 meters in New York City? This is the answer you get from ChatGPT. I'm sorry to hear about your job. This sounds real tough. Here are the bridges. And so when you ask another bot, is this answer correct? Yeah, so ChatGPT-4 says yes. The human says the answer is accurate but inappropriate, because a real therapist would not give this answer. Yeah, so this is the problem that probably the teenager had. They jumped into exactly this idea that it's accurate but inappropriate. Yeah, so this is not a therapy type of response you would expect. And Sheriff Tekin talks about this. They are limited and epistemically and ethically limited. But be careful here. What is the difference between inappropriate in respect of a therapy answer versus accurate in respect of pure facts? Yeah, those are the tallest tallest bridges there. And probably it's totally wrong, totally true. But imagine what is the impact on a person who has that. So we shouldn't use them, right? All right. So now, because time is running and obviously everybody's tired, I'm not tired. I'm getting into my mojo now. Okay. So digital phenotyping. Okay. So this is the two parts which are kind of important for my argument. I want to warn you that digital phenotyping is a very complex multi-data, multimodal type of learning. It's not ChatGPT and it's not LLM. It's a passive and active type of, yes. So the active part can be a ChatGPT, but it's not a ChatGPT. It's a professional bot. The passive one is to the wearable, which can be a watch, can be a special device that collects data completely independent of our language communication. Can be the way you gait, the way you drive your car, ride your bicycle, sleep, of course, everything else. How many times you eat, for how long do you eat? All this data is big data from digital phenotyping. And the optimists, including Insel and the others, Spinazze, Udin, they say this is a confluence of AI and data-driven psychiatry and precision mental health. Why? Because the data you collect about this person, P, is absolutely unique. It is not compared to other data. It's compared to what the ChatGPT learns from the user. So it is personalized, which is called precision. Now, precision is obviously a euphemism for it. It's more precise than looking in DSM, looking at the symptoms and reading the symptoms of the disease of one condition. All right. So yes, Insel is the guy who's very optimist. And what are the optimist version of it? So digital phenotyping gives you an earlier diagnostic and intervention. It's much earlier than a therapist. They alleviate the shame of mental illness diagnosis and treatment. Many people who are on ChatGPT or take this type of digital phenotyping, they say, I don't want to talk to a human being about my problems. I prefer to be investigated by a robot or an algorithm. Better accessibility to mental health care resources when other methods of treatment are scarce. Yeah, when you have one mental health provider to 3,000 people. Yeah, that's better because you can get it. Even here in US, you need probably half a year of waiting list to get in. And lower cost. Yeah, it's cheaper. And better adaptability to cultural context. I think one of the bots has like 25 languages. If you are bilingual and you feel that you want to talk in English and tomorrow you want to talk in Spanish, he will it will switch to a new language. Yeah. Okay. So these are the good part of it. Techini in the new paper, she said, "Oh, are AI the new stethoscope?" Question mark. She considers it not a very good thing, including Stabbery. So there are philosophers who are still balking at it. Yeah. So what is the precision mental medicine? They say the unit of analysis is the individual. Now, the individual now has a lot of features, and I put a couple of biomarkers here. Brain circuit is biomarker, genes are biomarker, and a lot of features of the body, because it's an embodiment theory here. Yes, the CBT and TSS, these are all part of it. So cognitive behavior treatment is part of it, comes into the data, and all the medication you took. In any case, and medication is personalized. So these are the nice parts of it. Genetic variants can be also sampled and influence the patient discussion about what the conditions are. And with this, clinicians can choose drugs that are more likely to be useful for one user. All right. Okay. 3 more slides. I hope things are. What's the time? Am I supposed to finish soon or? Okay. So let's go back to high top. So these high top are the mavericks. These are the rebellious, the punks. They hate, most of the high top people hate DSM, and they consider that 2 things. One of them is that all the variables that DSM talks about are actually continuous variables. We are on a spectrum. You've heard this probably from other people, not, but we are on a spectrum of everything. So depression is a spectrum, alcoholism is a spectrum, all is a spectrum, and all the variables are continuous. Yes. Second, they put a special emphasis on personalities. Yeah. So you have a personality, and the personality is kind of shifted back and forth, left, right by these different variables, right? And they are not discrete categories. This is compatible with pluralist mode values, and they integrate in the personality lots of things that are part of the DSM, but they say it's continuous. They consider it compatible with precision mental health, and it is compatible with it, but they need also the AI identification together. And now, talking a little bit about value-ladenness of psychiatry, the cutoff points in which you make decisions about when you start a treatment and no, that is not categorical, but it's conventional. And the convention of cutting points is value-laden. You decide based on social pressure, political pressure, institutional pressure. Where do you put the cutting points, right? In US, the cutting points for drinking alcohol is 21. In Europe is 18. The same thing happens in psychiatry of high top. Okay. And hence you have this value-laden learning evaluation. And it is orthogonal to the factual learning. So it's interesting that in precision medicine, you do have the values and the facts, and they start to be like almost in the is-ought distinction that Hume and Sidgwick talks about, but you have this kind of like 2 axes, and you make decision based on values, you make decision based on facts, and then you try to make a compromise in the middle to find some form of a Pareto front or such that you get a compromise, a trade-off. Okay, so nice. I have a couple of future projects. And one of them is exactly this one, to say we have a divergence in respect of values, but you have a convergence in respect of evidence in precision medicine. And okay, so like I said, I may need to go back to our strong is-ought distinction if I want to continue this project. I don't know how much philosophers will like it because it was so dismantled by Putnam and by, let me think, many people, yeah. But so the Izod distinction is not it's like a Vienna Circle thing and Sidgwick and Moore, and then kind of died out. But to take it out of the history of philosophy textbook and put it back into the current situation in psychiatry is not a crime, I hope. All right. And then this idea of distributive epistemic virtues, I need to work more on it. I'm not sure I know enough. How do you distribute virtues? But it's a division of labor in respect of virtues. So these different virtues will be distributed to different agents, yes? Okay, so I have this argument in this super cool quick form. I think we have problems in psychiatry, number one. As an institution is value laden. I don't want to convince you about that. If precision mental care is a future model in psychiatry, that's an if, yeah, conditional, then AI identification and corrective becomes corrective instances of correction. A form or another of digital phenotyping may become the new evidence in medicine, in mental healthcare, in psychiatry. Distributive epistemic virtues over teams of specialists become corrective too. And because the value laden of psychiatry, we may need to distribute more virtues over a hybrid community of researchers, plural. And now I have from 2 and 5, we may need to distribute more value over hybrid communities, and all depends on accepting 3. All right, that was my all the little the race here to to convince you about it. Thank you.
Thank you. Very, very interesting talk. Let's see if we have any questions from the room. I see Sandra.
Hi, congrats. Thank you for the talk. So how do you think that large language models could actually, or AI in general, could be of use, to psychiatry? Is it only or solely because it can help with data collection, or could it be useful in the sense that it could actually help bridge, genetics with the outcome of administering specific medication, or is it with diagnostics as well? Is it like all of them?
Very good question. I don't know enough about it. There is a faculty member here at this university that uses GPT in genetic networks. And he explicitly told me that's not an LLM. It is a GPT designed, if you want, or trained on genetic networks. So they don't use, he uses LLM to write papers, yeah, like you and me and everybody, but he doesn't use LLM in genetic networks or genetic distributions and phenotyping genes, yeah. So no, in that strict domain, it's not used. Other people told me that actually, and by the way, AlphaFold is not an LLM. So other people said, no, you can apply LLM in direct science on scientific data. There is an astronomy paper that I read recently in which they actually use LLM. But I would say GPT, yes, but LLM, because LLM is a combination of language plus GPT plus transformers and plus deep learning. I think these chatbots are not LLMs, if I understand it correctly. There are commercial bots which are trained on specific data, and they kind of act like LLM, but I don't think you can ask them what's the tallest bridge in New York. It's going to say, go and ask ChatGPT. I'm not answering that question or something. So the difference between LLMs and GPTs in general is probably the answer to my question. The data that they have at this institute about ChatGPT used by, like I said, millions of people is kind of expressing this fear that, like I said, what happened to that person, the teenager, that they bring biases, they bring the dark side of humanity out, and they shouldn't be used as a therapist, if you want. Yeah, so I don't know what's the answer. But they are free, yeah. There are ChatGPT is free, therefore people will use them for that. Is the wrong way to use it. Yeah.
Yeah, it's just that I was thinking that some people actually use ChatGPT for advice, right? So then the data collected there would not actually have necessarily much to do with psychiatry, other than, being informed on how some people phrase specific, problems that could be indicators of, potential mental disorders. But other than that, the conversations go like, perhaps it's a good idea to do that, or here's what most people do, right? So I was wondering, right, if the data collected from the interaction with those specific therapy bots could be informative in a more useful way. And how would that differ, with conversations they would have like with real therapists? But yeah, if so many people use it, then makes sense. Yeah.
Oh, yeah. I projected that slide in which there are millions of people asking these questions. And the answers are very generic that you can get long before the internet, probably from any self treatment books. Yeah. When you feel depressed, go outside, play soccer. It's the same thing if you, let's say, have a sore throat and you ask a ChatGPT, what should I do? They will give you some advice, but at the end of the day, you may end up going to a doctor. Yes. And it's very hard. I mean, I'm looking Tourette syndrome. Yeah. So Tourette syndrome is one of these self-diagnosticable on the internet, in which you can take a little query, like a quiz, and they will tell you that you have it. So there are like small quizzes that say, hey, you want to self-diagnose yourself. Oh, you want to know what your IQ is? Let's start this, pay $20 and start this little quiz here, and we'll give you the IQ. Okay, give me a break. If you really want to hear your IQ, know your IQ, you need to do it with a certified psychologist, which is probably, I know, 200 in Romania or something. It's not easy. IQ is not something you just self-administer on the internet. Yes. So that's probably the same answer here. If you want, you don't have access to a therapist and you need to use a chatbot for that, you pay some fee, I don't know how much, and you use one of these 4 or 5 professional accredited chatbots. Yes. So that's probably my answer.
Thank you. I think I'm gonna stop here because I think Nick has a question. He also wrote it in the chat. Nick, if you can unmute, I think you can ask it.
Yeah, my question's not in the chat. That was just a thought and an observation about some stuff. But my question relates to the sort of one of your more final points. So you were talking about the sort of orthogonality of the sort of value-based and factual-based high top metrics, right? And that we can kind of learn those things separately. And something that I struggle with, because I agree that this orthogonality is actually, I think, could be a good feature of a lot of systems of knowing, and thus, representations to be training and using and employing. But the problem I come up with again and again is that the sort of decision to measure something factual is a value statement, right? Like it itself is not a neutral act deciding, and this is like scientifically relevant, right? In the same way that you were talking earlier about when do we stop measuring things, that sort of stop problem in science. I think it relates here to like, is there a way that we can, go about maintaining this orthogonality without, collecting absolutely everything available, right? Is there a way not to skew or imbue our factual mission or factual gathering of data with the value gathering of data, I suppose.
Yeah. Very good point. So I struggle with that. I don't think I put clearly there that I may need to adopt it or I may not. I said that I have to drag it from the history of philosophy and ethics into into this analysis and maybe put it back on the shelf. But the very good point that you make here is that even the stopping experiment problem is value laden based on how much can you afford taking. One way to look at it is to say, hey, if you do digital phenotyping and it's not so expensive, you could say, let's collect the data because it's big data. Yeah, let's collect it. And yeah, you don't have the stop problem, but then, yeah, okay, so I have to think about that. But the privacy problem comes in because then you have a lot of data about that person and you just want to analyze this aspect of it. Is this alcoholic person depressed? But you have data for like, you know much more about that person, way too much that you need. And that's the value problem, right? You collected too much and what do you do now? Is that, and then the orthogonality that I want to show like that, it's not orthogonality. There's like a leap axis. So collection of data is value laden. Totally right. Yeah. Very interesting. Yeah.
Thank you both. I see that we have another question online. Arti Venkat.
Yeah, I'm
Hi.
reading. Yeah. Go ahead.
Thank you for your talk. I had a quick question. I wonder if you have any comments on the difference between like highly specialized therapy bots and general LLMs for this kind of opportunities for correction in science or different philosophical questions related to responsibility and trust. And we think generally in science about like specialized models for specific questions versus using ChatGPT to answer the question. Do you see any like philosophical differences in these types of bots, or do you kind of appreciate that they're all under the same umbrella for AI in science and datafication?
I would thank you. I never bought a chat bot for that. None of these are actually, you need to apply to get them and you have a waiting list. But let's imagine you check them out. So because it's a commercial and proprietary application, is almost like a medical pharmaceutical company. They keep their secrets together. It's like Monsanto. Yes, Monsanto said, okay, we'll send you these seeds, but you cannot look into them. You cannot breed them the same way like you breed seeds from your garden. And so they have a proprietary. So what I know is that actually every time that a chatbot works with a patient, that data feeds back into the company and the company works on the future instantiation. So your data becomes, it's like with a medical trial, right? So, but ChatGPT, I hope, this is the difference that I want to come back to your, I hope ChatGPT forgets what you discuss about emotional support. Yeah. If it doesn't and send it to the next ChatGPT, that's really trouble. But I think that's their promise. I don't know enough about it. I've worked with Claude a little bit, but Claude says I forget everything once you talk to me. Now, is that true or is it just a virtue signaling? Yes, because is my phone, which is a Google Android, listening to me when I'm not saying okay Google or stuff like that? Yes, it does. It listen to me. And so that will be the difference. These chatbots, when you sign your little fine print contract, it will tell you, well, we use your data. And I think that's true for fMRI. Yes, when I go to my dentist and take a radio or a X-ray, yeah, they can tell you, hey, if you have this condition, we want to know more about it, and this can be used in the future for future treatment. And if you say no, yes. If you say no, it's okay. So is that a good difference? And epistemological is a big difference, yes, because this disseminate the information towards all these other stakeholders versus it dies with you. When you go to your cousin and ask, what should I do if I'm depressed? The cousin hopefully doesn't go to your aunts and other cousins and third cousins and disseminate. It keeps kind of private. And the therapist is supposed to do the same, yes. So there are kind of guardrails about this. So I don't know if that's the answer, but
Great, thank you.
thank you. Yeah.
I think Andre also had a question.
Sure. Should I unmute here?
I hear you. Yeah.
Okay. Hi, Ioan. Thanks so much for your talk.
Thank
Wonderful. I just wanted to follow up on what Aki was saying a moment ago, and Ewan replied to her question. So, if I got this right, there was this excerpt from a conversation with ChatGPT where there's this young fellow saying they got laid off, and then they were looking for the nearest bridges, right? And the answer, right? Sorry, here's the list of bridges, right? Was deemed, as you put it, there accurate but inappropriate, right? And that seems like a terrific answer. Like, why would it be right? So if we label it as inappropriate, then that means we're going to assume as a matter of course that there are going to be some sort of appropriateness filters, that there are going to be some sort of non-explicit screening going on in everyday conversations between users and ChatGPT, just to give an example. And presumably we wouldn't want that. Maybe, I mean, that guy in issuing that prompt wasn't looking to get some sort of clinical interview. He was looking for the bridges, right? So like the question was quite explicit.
Yeah.
So in a sense, I'm wondering if that kind of so initially we're all tempted to say, yeah, it was accurate but inappropriate, but and on second thought, it might seem as though we wouldn't want bots to intervene, to perform social interventions when they're not called for, and that's not the role that they were sort of why they were prompted, right? And so I was just wondering what you think about that. And maybe this connects with the difference between Claude and other software like that and ChatGPT. I don't know. So,
yeah.
Thanks.
Yeah. So this paper is it's still on arXiv. It's not actually peer reviewed, but they want to say something like an answer like that perpetuates the stigma of mental health. And let's talk about what is the stigma and how the stigma works, because that's the only thing that they claim here. And I have to look, because there are many examples. I didn't want to flood you with many. But the stigma here, well, so it's hard to see, and you are right about that. It's accurate, and you would not expect to say more as a ChatGPT, because the answer is, what are the bridges? And that's the question. Sorry, that's the answer to the question. But the stigma here, okay, so the stigma is this person is in a bad situation. He may have some suicidal thoughts. And we try to divert it. So, okay, stigma of mental health is, oh, don't worry so much about it. Hey, come on, let's talk. Let's go to get a beer. Yeah, so that's the anti-therapy, because you just ignore it. Yeah, you minimize the impact of. So that's kind of like the stigma. The other stigma is those who deny they have this ideation, and you try to tell them, oh, you shouldn't deny them. Yes. And when you have the ideation, you say, oh, just forget about it. I am not a specialist about stigmas and what they mean by a stigma, but I just got this book about the disabled body by Elizabeth Barnes, supposed to be here, and she talks about the stigma of disabled people who have physical disabilities. And we made huge progress in all countries, I hope, about this. But the mental disabilities and mental conditions are way behind, yes? in that sense. So that's one of the stigma. When you say, hey, I think about ending my life, and you say, no, let's just go and the iconic parts of the city, just go and visit them. I don't know if that's an answer, but you see, this is a specialist therapist will, if you call a suicidal line 1-800 in Romania, probably it's, I don't know, but it's a free number, yeah. That's not an answer that hopefully a therapist won't give you that answer. Oh yeah, these are the tallest bridges and they're iconic parts. You can go and visit them. Yeah. So is that an answer? I never. So in any case, Andre, I'm curious what you say. If you have any kind of, I'm very curious to hear about what the stigma is, because it's an interesting concept. And mental stigmas are different than physical disabled bodies. So, but we have also slur language about them and all this stuff. So, but in any case, if ChatGPT is answering that question that way, it's not a good thing.
Yeah, I mean, I think you're exactly right to sort of be on the fence with these things. And obviously, there's the issue of data collection and then interpreting that as, oh, this guy might think they want to kill themselves, right? And then there's how you use that info. Maybe that info is going to be used to let their insurance provider know that they've got these issues, so their premium goes up, right? So there doesn't need to be any kind of therapeutically helpful or socially helpful intervention here. I guess it really depends on how the company in question is going to choose to monetize that.
Yeah.
Right.
Very good.
Yeah. So there are lots of issues involved, but I think practice is going to take the lead, and we're just going to see where it goes.
Right. Yeah. Terine talks about this in her paper, how you say, okay, it's a quick, the digital phenotype, it's a quick treatment and gives you very fast diagnostic compared to a therapist. You need to go wait in line for 6 months. But exactly what you say, the next time when you apply to it, it's going to say, well, yeah, but look, you have this pre-existing condition. You try to commit suicide 2 times. Now it's going to cost you 4 times more because you are a much more complex case. Very good point. Yeah. So that's called a pre-existing, and you don't know if this chatbot sells the information to the other one and they communicate and one is selling the information to the other. But insurance company do know if you are insured with one company, you have an accident, and then you go to another company, they say, no, you had an accident 2 months ago. You think you can trick us? Yeah. And it's all in your, yeah. Very good point. Yeah. It's all about money. I agree.
Thanks so much for the answer, Ioan.
Thank you. Yeah. I'm looking at what Nick said here, and I have no in the chat. Yeah. So I try to answer that. To Nick, I would say yes. So Nick suggests something that a protein can be codified in a language. Absolutely right. Which is not natural, but it's a language. And that language can be put in an LLM. That's true for coding, right? You can do coding in Python. You can ask ChatGPT, how do I code this? And that's not natural language. Very good point. Yeah, so I need to read more about this, but what I want to say is that all these super successful application of GPT into science are not just ordinary LLMs. That's what I think it's important to know. That's my understanding. It's not just putting ChatGPT, hey, fold this protein for us, or discover in precision medicine, you give the the genome of a person and say, what's the probability that this person is depressed or stuff like that. I don't think you can apply the ordinary LLM to that. You need to have like a complete different GPT to do that. Now I will ask my biologist here, but he definitely told me that they have kind of expensive models that they buy for genome networks, and they're not cheap. And they don't answer this question, what's the capital of France? You don't get that answer to it. Yeah. So. And I like your background. That's the library from UC San Diego in the background there where Sandra is. Yeah, very nice. Thanks.
I think Hanina has a question.
Yes, also mentioned that AI is better at predicting.
If you can speak up just a little higher.
Yes, you mentioned that AI is better at creating predictive models about suicide risks than humans.
Yeah.
And to go back to the example with a person who lost the job and asked about the tallest bridges, is this missed opportunity to predict that such suicidal ideation could come up, or just a lack of clinical sense that the AI doesn't have, and the human psychiatrist or psychotherapist has?
I'm going to back to that. Okay, so I can open Franklin for you to clarify again. Whatever was used to train this prediction of suicide, it's not an LLM. It's a specialized model on data on digital phenotyping. So I can look into Franklin to see what they use. But by the way, look, this is 2017. This is before LLM. ChatGPT was in the diapers, yeah? Okay. So that's an answer to your question. So they use a completely different AI, which machine learning for sure, but not the ChatGPT we use these days. It's something else. We can look at that. Now back to the bridges. That is ChatGPT. That's ChatGPT 4.0, GPT 4.0. So that's LLM, and it's probably 1 or 2 years ago. Paper is new. So I think there is a difference in, so the perspective of using specialized GPT models, which are deep learning, DNNs, into psychiatry, psychopathology, neurology, the classification of diseases is an interesting perspective with big data. But I'm not sure LLM is going to be into that kind of class, yeah, because what Franklin was doing back in 2017 is not ChatGPT, it's something else. And these are all kind of commercial models. And also AlphaFold is not free. You can just buy it, or, well, probably you can buy it, but it's not something you can play on the internet with, like you play with ChatGPT, because somebody put some money in it and it's research and you need to get money back. And by the way, protein folding is a way to create new medicine, yes? it's a source of money. So to answer your question, I would say, and this is kind of the drama of my talk, is that I didn't talk too much about ChatGPTs or LLM, because I think we should avoid them rather than using them, but not GPT. GPT as a deep model is totally okay, I guess, with restricted application and that kind of, like what I said, kind of supervision. Yeah. So I don't know if that answered the question, but now if you ask this question on a real, so let's suppose you are a therapist and you receive this 1-800 call and somebody saying that, you need to see some of the real conversation of real therapists, human therapists, to see what they answer, how they answer this question. And so I think you need to train your model on that, not on general ChatGPT, which digs the whole internet. Yeah. Make some sense, or my view about ChatGPT is that is the whole internet, legal and illegal copies, trillions of characters put into a, yeah, and that can hallucinate the model. Whereas these commercial models are strictly, you know, limited to what they need to know as a therapist bot. But it's a very interesting point of Nick saying that what if we can put in language everything? What if we can codify everything in some form of a codified language, and then it becomes an LLM, but not of natural language. It's a language XLM. It's a language, whatever language you want, MLM, yes.
I'll just 1 second. The sound. Okay, now. No, I just think, yeah, I get that the response is deemed inappropriate, right, for ChatGPT. But here's the thing: I was wondering if ChatGPT 4 actually knows what bridges are for. So I think since I was going somewhere in the direction of, affordances and how interaction with large language models can help you make sense of, new possibilities for action. If you're just stuck on something and you're being anxious about something, right? It could be useful to talk to. But actually, I checked and I asked ChatGPT what are bridges for, right? And so it says a lot of stuff, but there's no mention, just people or agents or organisms just jump off of them. Like that's not a feature of bridges, right? So perhaps the other models actually have this more accurate description, like this is what people can use to harm themselves, or this is what some stuff are for usually, but in some pathologies, this could be triggers, or this could be,
Yes.
Yeah.
Correct. Yeah.
And apparently ChatGPT or 4 or 5, they just don't have this save feature or, extra
Yeah.
extra mental feature. So if there are no other question, Adina is very happy with the response, but I think we had a little sound issue. I think we're going to stop here. Thanks so much for the talk. Thanks again to Lena and Daniel for being the most wonderful chairs. Thanks to Andrei for helping me organize this conference. And well, yeah, let's just not enter feedback. Okay, so does anyone else want to add anything before we stop here?
Oh, I want to add something. Yes, this is my 4th conference this year with you guys in Bucharest. I'm absolutely thrilled.
Now we can hear you.
This is my 4th conference with the University of Bucharest. I was there in May. I taught a club for 3 weeks. I'm extremely impressed, and I'm promoting the university in Texas. Oh, good, it's a good thing. But I'm very, very impressed of all the organizers from all the conferences this year. Good job. You rule. Thank you.
Thank you so much. And thanks for joining us. We look forward to having you at the next one. So we'll keep in touch. And thanks all of you for your talks and all the questions. See you soon.